Hello, everyone. Today we have an interesting case of GN. She is a 46-year-old woman who was referred uh, for gradual onset of 10-pound weight gain with new onset leg edema and proteinuria 3 plus in her urine analysis with trace blood as well. She denied any history of recent infection, joint pain, new rash or systemic manifestations. Physical examination was benign apart from blood pressure of 142/82 and pitting edema +2 bilateral. And laboratory testing showed her creatinine was 0.8, albumin 3 grams, total cholesterol 278, and total urine protein creatinine ratio of 6.8 gram per gram of creatinine. Uh, she is up to date for her cancer screen. Her ANA came back negative. Hepatitis serology was negative and complement level were normal. You initiated supportive care for her nephrotic syndrome with sodium restriction. You started RAS inhibitors, mild diuretics, and statin therapy. And the question is, which additional test would be most helpful at this point? Do you need to proceed to a kidney biopsy or do duplex ultrasound on her renal vessels, or check her antiphospholipase A2 receptor antibodies, or check her antiphospholipid antibody, or order renal scintigraphy to evaluate the kidney structure and function? And the right answer is to check her anti-BLAR antibody. The discovery of anti-BLAR antibodies in 2009 and its relationship with adult idiopathic membranous nephropathy was a turning point and a paradigm shift in management of membranous nephropathy cases. This is a very, very good, sensitive, and a specific biomarker, non-invasive biomarker with positive predictive value. These autoantibodies are responsible for primary idiopathic membranous nephropathy in about 80% of cases and reflecting approximately 55% of all membranous nephropathy, including primary and secondary cases on kidney biopsy. The discovery of this antibody allowed us to use a non-invasive biomarker not only to diagnose membranous nephropathy, but also to see the response to therapy. And as you know, that immunological response and the remission can happen up to 1 to 2 years before clinical remission. So it's an early biomarker, have both diagnostic and prognostic importance. Data are highly suggestive of a causal relationship of this antibody with the membranous nephropathy pathogenesis. So it's not only biomarker, but also it's one of the antibody that is implicated in the pathogenesis of the disease. The circulating antigen, either endogenous or exogenous, the immune complexes, or even the immunoglobulin become trapped in the subepithelial side of the glomerular basement membrane and thereby initiate immune complex formation in the subepithelial position. Detection of anti-BLAR antibody represents a non-invasive testing that can establish diagnosis of primary membranous nephropathy and provide the baseline titer that helps for follow-up, and avoid doing invasive kidney biopsy with its complications. So kidney biopsy should be considered only if anti-BLAR antibody is positive or in patients with atypical presentation or rapidly deteriorating kidney function. There are no clinical signs to warrant immediate testing for antiphospholipid antibodies, which is associated with hypercoagulability, or need for duplex ultrasound to rule out renal vein thrombosis in such case. Kidney function was normal, so renal scintigraphy is not going to add any significant information in this patient management. Um, Here is the reference for the case. This was published in 2021 in the American Journal of Kidney Disease. And of course, this was published by Beck Lawrence, who is one of the first investigators and the founders of the anti-BLAR antibody. Thank you so much and have a good rest of your day.